Well, good morning, everyone. If we haven't met, I'm TJ Woodward, the founder and creator of Conscious Recovery, and I'm going to keep this really brief because I have the honor of introducing someone who actually can make me speechless. And I genuinely mean that. And you know, no pressure here, the good doctor. Probably one of the most brilliant minds I've ever met, and also one of the most authentic, down-to-earth humans. I'm not reading a bio, but he is the founder of the Camden Center, and of course, an early adopter of conscious recovery, so I thank you for that. Dr. Jason Schiffman, everyone, prepare for an experience. How's that?
Oh boy, thanks. All right, is this working? Yes. Okay, great. Okay, so let's just lower all the expectations after that. So thank you, TJ. Although I do have to say this is the first time I've given a lecture where I wasn't allowed to have any PowerPoint. So I have no idea how it's going to go. Hopefully better than I'm expecting. So, all right. And the topic for today, when TJ told me about it, was just emerging treatments and emerging modalities. And so it's a pretty broad topic, and before I jump into it, maybe just to tell you guys a little bit about my own background. So I, as TJ mentioned, I'm a psychiatrist. I started the Camden Center. I also run the UCLA dual diagnosis program. And when I first started working in this field, which is about 10 years ago, this term dual diagnosis was the outlier term. It was like, and that why it was a special term. It was this special group of people who have addiction that also happen to have a co-occurring mental health issue. And what was apparent to me at the time, and I think the rest of the culture is, I think, moved more in this direction, is that I don't think you end up with a substance use disorder unless you have a co-occurring mental health issue. So, I mean, maybe there was one alcoholic 100 years ago who wasn't anxious and depressed, but I've never met one that didn't have at least some form of internal chronic emotional pain that got numbed out when they were drinking, right? And so one of the things that I talk a lot about with the patients at Camden Center and the patients at my UCLA program is, the problem isn't actually the substance use. It's not actually the self-injurious behavior. It's not the eating disorder. Most people who drink alcohol don't become alcoholics. Most people who use cannabis products don't become cannabis addicts. Those of us that develop problems with these things, it's because we had a different problem that predated that. And what becomes the problem that causes these big crises in our lives that result in us presenting for treatment starts off as a solution. And so I think that because people don't come into treatment unless there's a crisis, right? The shit kind of has to hit the fan for somebody to say, okay, I'm going to go into treatment. A lot of attention gets paid to the proximal cause of the crisis. It was the drinking or the drug use or the suicide attempt or the self-injurious behavior, the eating disorder. And those things absolutely need treatment. But I think what's really, really important to recognize is that anybody who shows up asking for help with one of these things also has another quieter problem that's waiting for you underneath that. And when you get them to stop doing the thing that's causing the big visible problems that leads to the crisis, you've also taken away from them essentially what was likely their only coping mechanism for this other thing. And so, I'm going to talk about some emerging treatments related to medications, but I always like to start off any talk that I give with that general picture because I see much, much, much more commonality among all of the different patients and all the different diagnoses than I do differences between them, right? So, you've got these diagnoses like schizophrenia and bipolar disorder that clearly those are neurologic problems, the solution for which is medication. But for pretty much everything else, if you get all the way down to the source, all the way down to the roots of like what was the origin of this problem, it all comes back to the same place, and it all comes back to a sense of self that's rooted in shame, or at least that's my belief, right? So there was a psychoanalyst called Michael Balint. He's not a particularly famous one. Most people haven't heard of him. He was I think he was Hungarian. And he had this idea that he came up with called the basic fault. And basically this idea, and it was mired in all of this psychoanalytic bullshit and jargon, so I don't actually recommend you go and read about it, but extracting the relevant pragmatic piece, which is that, humans are a really unique animal. And the thing that makes us unique among our thumbs and other things that other animals don't have is the fact that it takes about a decade before a human child can survive on its own. Compare that to like a horse or a zebra or a giraffe that kind of comes out and wobbles for 45 seconds and then stands up and can do basically 100% of what they need to do to survive for the rest of their life. So humans, we're pretty much incapable of making it on our own until 10, 12, 13 years old. And so what that means is that evolution made our brains such that when we're children, the most important survival goal is forming and maintaining a solid, secure attachment with a loving authority figure. And if you can't do that, you're dead. I mean, for real, you're dead. I mean, not now because there's orphanages and stuff like that, but for the vast majority of human history, children that were not able to maintain a stable, loving attachment with important adults around them didn't make it. And so there's this word trauma that we all use so much now, right? And I think one of the things that is confusing for people outside of mental health care, in fact, maybe even for some of us in mental health care, is, wait, I know trauma is like when somebody goes to war and gets shot. And I know trauma is when somebody gets assaulted. I know trauma is when somebody gets raped. But how come we're now using this word trauma for the fact, for things that happen during development? And I think it's really important to understand why things that are sometimes called little t traumas or developmental traumas are just as traumatic from a psychological standpoint as these big overt traumas are for adults. And the reason is because of this fact that for children, lack of an ability to form a stable attachment with a loving adult induces in them the same level of emotional distress as when adults experience life-threatening events. And the reason is because for most of our evolutionary history, that was a life-threatening event. So what happens is, and getting back to this basic fault idea, is children are hardwired to be little antennas for whether they're being attuned to by loving adults and then later peers. And if they make that connection, it induces in them a feeling of safety, it induces in them a feeling of self-worth, of relaxation, and it kind of checks off the first most basic survival need, and then allows the child to wonder about other things like, oh, what do I like? What don't I like? What does it feel like in my body? Things like that. But until that survival need gets checked off, children don't pay attention to that. And what happens is that if that attachment either isn't able to be established or it breaks, those feelings of well-being and security and self-worth get replaced by feelings of anxiety and emptiness and shame. And it's really important to understand this last piece of shame, because I don't think it's necessarily obvious why would the child feel shame with the lack of attachment. And the reason is because given the importance from a survival perspective of that attachment, children always take responsibility for its rupture. This is why when you see movies about parents getting divorced, somebody always has to go and explain to the kids it wasn't their fault, right? So why is that? It's because children always assume if there's a rupture in that attachment, it was because something was wrong with them that made them insufficiently lovable for that attachment to be maintained. And that's the genesis of our basic fault. And we all have one to some degree. Nobody got perfect attuned parenting, right? I know all this shit and I'm still not a super great parent for my kids, right? Because the reality is that it's hard to be a good parent, right? I literally have feelings of want to murder both of my children, And I think it's important to actually be able to say that out loud because if you don't acknowledge that sometimes you want to, be a normal feeling of being a parent is wanting to murder your fucking kids. if you don't say that out loud, then what happens is you end up like my dad, who actually does come close to murdering your kids, right? Because then you act out on it, right? So it's okay to want to murder your kids. It's not okay to actually murder them, right? You know, it's okay to be really frustrated with them and to have feelings of like intense rage, but you just know to do something else with that. So, so what happens is we all emerge into adulthood with some degree of a basic fault. And, you know, to the extent that that was either above or below a certain threshold for our own particular temperaments, it either becomes sort of a really defining feature of what it feels like to be us as an adult or not. And I think those of us that go on to become addicts, it's because that sense of self that has that shame-based basic fault in there is active enough that we walk around in the world viewing the world and experiencing the world through that lens of feeling that there's something unlovable or bad or invalid about us. And that's what induces anxiety and depression. You know, anxiety and depression in and of themselves are not inherently pathological or bad. If there's a tiger right here, it's appropriate to feel anxious. You know, if you lose a job or somebody breaks up with you, it's appropriate to feel depressed, right? But it's not people who feel anxious when they're around a tiger or depressed when they lose a job that go on to become addicts. It's those of us that feel anxious or depressed all or most of the time in the absence of something dangerous or sad happening right now. And the origin of that is this shame-based sense of self. And it's a vulnerability to the development of addictive behaviors, because if you basically feel okay at baseline and then you go and you party like a normal kid, then you feel euphoric and you come back to feeling okay. But if you walk around feeling emotional pain all or most of the time, then when you go out and party, you don't just feel euphoric, you get relief from chronic pain that's then waiting for you there when you come down. And then that's the origins of this thing that starts off as this wonderful sort of anesthetic type solution, but then goes on to become its own problem, right? And the irony is that then, you know, when we start running into problems with these addictive substances and behaviors, we then end up feeling shame about that, which reinforces the whole thing we were trying to treat to begin with. Okay. All right. 12:30, right? Okay. So good, because I wasn't really sure how much I had to say about the actual emerging treatment. So, but that was the important stuff I just said right there. So, all right. So when I think about emerging treatments, I think that I probably, like almost everybody else in the mental health care field at this point, is probably thinking of the same thing, which is these actually three substances, these three medications that are kind of working their way through the approval pipeline. One of them is already approved, that often get grouped together as psychedelic medicine, right? And I have a pretty strong opinion about a lot of this, and so I think that what I just as a caveat to before I get into anything else is, you know, I'm going to let you guys know sort of the factual stuff about these medications that are called that are getting grouped actually inappropriately into one category and called psychedelic medicine. I'll let you know the scientific parts of it, and then I'm also going to tell you my opinion about it, and I'll make sure that I make a distinction between those two things. You know, and there's a lot of room for opinion, because at the end of the day, despite the fact that psychiatrists like me like to promote the image that we know what we're doing in the same way that other doctors in other fields know what they're doing, the reality is we have no idea how the brain as an organ produces consciousness. We have no idea why, when a molecule fits into this kind of receptor in the brain and changes the way that neurons are firing, it results in a subsequent characteristic change in sensation or consciousness, right? But we use lots of sort of jargony vocabulary words to create the illusion that somehow like what we're doing is on the order of the same thing that doctors that treat, I don't know, diabetes or know what. But when you say somebody's got diabetes, that means something. Like, we know what diabetes is, right? When you say that somebody is in a major depressive in a major depressive episode or has a major depressive disorder, you know, that's it is something, and I think that it's meaningful, but it's meaningful in a different way than saying that somebody has type 1 or type 2 diabetes. You know, the way that we make psychiatric diagnoses is through this listing of symptoms and then saying, well, if you have 4 of these 9 symptoms and you have them for at least 2 weeks, then we're going to put this label on it. It's a little bit like as if you were to go to your doctor and say, well, I've had a headache and stomach ache and sweating for 2 weeks, and he'd say, "Oh, I know exactly what this is. It's headache, sweating, stomachache disease." That's what you've got, you know? That's basically, when we say major depressive disorder, that's what we're doing, right? Okay. Let's talk for a minute about, or the remaining minutes, about these emerging treatments. So there are 3 drugs that are currently being described as psychedelic medicine. Ketamine, MDMA, and Psilocybin. They are actually very, very different drugs from one another. They have different mechanisms of action. I'll explain what those are in a minute. They have very different effects. And as a consequence, I actually think they have very, very different risk-benefit profiles. And to me, the most important thing in this discussion about new interventions, particularly these drugs, is to remind ourselves who we are and what we're doing. So we're not shaman, or I'm not a shaman. I'm a doctor. And I have a responsibility when people come to me to actually do what I think is going to help them, and do it in a way where it minimizes the amount of harm I'm going to do to them. And I think the thing about each of these drugs is there's a huge promise of benefit. I mean, they're powerful, powerful tools. But power is both power to do good and it's power to harm. And I think that a way to look at these is a little bit like the advent of surgery in the medical field, right? So when surgery first came around, I mean, you can do things with surgery that you cannot ever hope to accomplish with just regular medicine. But you can also screw somebody up pretty bad by doing surgery on them, right? You don't wash your hands, you go and you cut an artery, you do the wrong thing. And I do think that there is an exuberance right now in the mental health field about psychedelic medicine that is transfixed by the potential benefits. And I actually think that there is truth and I am actually really optimistic about things that are potentially going to be able to be accomplished with these meds. And at the same time, I also get anxious because when I see people rushing in and they're like, I'm opening up a clinic and it's going to have ketamine and it's going to have psilocybin and it's going to have MDMA, it's usually people that have been, I think, either through their own experience with those drugs or through their experience around other people having seen tremendous transformative experiences on these drugs. And it's right and good and appropriate to feel excited about it. And at the same time, when people come to us for treatment, there's a huge responsibility there to make sure that we're actually making sure that what we do for them doesn't put them at risk. And even just the fact that ketamine and MDMA and psilocybin are talked about in the same breath now, to me is an indication of, this feels a little bit like the internet in the 90s, right? Where it was just all like, oh my God, it's gonna be amazing, and you just got all this huge bubble, and the thing was, the internet was amazing, is amazing, and we're living now, 20 years later, the promise of back then. But where are all those people who were like, I'm gonna take this internet and I'm gonna make robots for you, and you're never gonna have to do the dishes again, and whatever it was, you know what I mean? It's like, the people who rush in are not necessarily always the people that you want wielding the scalpel, right? So I think the thing is, and now I'm going to talk about all the promise of it, but I do feel like that's a really important thing to know, because I do get worried, because when I hear people talking about these interventions, I hear a lot about all of the promise. I don't feel like I'm hearing a lot of talk about the risk, and that's not to be like you shouldn't do this. It's just more a matter of taking seriously our responsibility of not causing harm. And I think part of the issue is that there is a little bit of this, what I think now is a bit of a straw man narrative about, there was these conservative people in the 50s who wanted to hide these magical drugs from us, which is actually true, right? So, there was this thing that happened where there was this incredibly sort of puritanical and not evidence-based process through which many, many drugs got put into what's called Schedule 1 by the DEA, and that basically means that they're deemed to have no medicinal benefit whatsoever, and inappropriately, these drugs not ketamine, but MDMA and all the psychedelic drugs got put into this category. And I do think that there was an appropriate pushback in sort of the counterculture against that to say, hey, listen, there's actually potentially benefit to these compounds. They shouldn't be Schedule 1. And we're now actually at a point now where we're seeing the fruits of that labor. I do worry a little bit, though, that it feels a little bit to me like when, cannabis took this weird detour through medical cannabis on its way to legalization. And I can't tell you how many 20-year-olds I treat now that grew up with all of the propaganda that was just as wrong as the Just Say No propaganda, right? So there was the Just Say No propaganda, which made cannabis as bad as cocaine and heroin, but then there was all of this other just as bullshit propaganda on the other side when they were trying to get cannabis legalized for medical purposes. That's it's good for everything and there's no risks whatsoever. If you've got gout or anxiety or whatever, just take it, And the reality is that it's pretty safe. Cannabis is a pretty safe drug, but it's like alcohol. It's not gonna magically cure all your problems. And if you're taking it for anxiety, that's probably not the best treatment for your anxiety. So I do worry a little bit that the pendulum swinging from sort of that George Bush Sr. kind of orientation towards these drugs is now a little bit too far over on this side. It's put acid in the water, So I do think that we need to strike an appropriate balance between those things. So, okay. So let's talk first. So what I'll do now briefly is I just want to talk about actually what are these three different drugs and what are the potential risks for them and what are the potential benefits for them. Okay, so ketamine. Who here hasn't heard of ketamine at this point? Nobody. Okay. So ketamine is a molecule that's been around for a long time, used for many, many years primarily as for anesthesia, usually for children. And the reason it's used for anesthesia for children is because children are particularly susceptible to the respiratory depression that happens with opioids and the other types of drugs that are usually used for sedation. And appropriately, surgeons don't want to kill the children when they're putting them under anesthesia. And so instead of using opioids and other medications that can cause respiratory depression, they would give them ketamine. Ketamine is what's called a dissociative anesthetic. And what it does is it actually, when you give someone ketamine and then perform a painful procedure on them, it's interesting. If you listen to the report, it's not, so they're still conscious, and it's not that they don't experience the pain, they just say that they feel like it's happening to somebody else. And what ketamine is doing on a molecular level, or let's say a biological level, is it's fitting into a receptor in the brain for a neurotransmitter called glutamate, which is the main stimulatory neurotransmitter in the brain. And there's actually different glutamate receptor subtypes, and one of those subtypes is called the Nmda glutamate receptor, and ketamine fits into that receptor and blocks it, meaning it fits in there, it doesn't make it fire, it doesn't make it not fire, it just sits in there so that glutamate, when it is released by what's called the presynaptic neuron, when it gets released, it can't make this receptor activate anymore. So summing that all up in a jargony term, what you would say is that ketamine is a glutamate Nmda receptor antagonist. Fits in there and blocks that receptor. Now, why does that cause dissociation? Why does that cause any of the other effects? Nobody has any idea why. So there's a lot of room for hand waving, and now comes my opinion part. So before I tell you my opinion, let me just give you an interesting history of how ketamine started being used for psychiatric conditions. So there was a very small study. It only involved 10 patients. It was done at Harvard. This is probably about 20 years ago. And it was with 10 chronically suicidal patients. And they were given ketamine infusions, meaning through an IV. And I think either all 10 or 9 out of 10 of them immediately got better. And it persisted for, I think, 2 weeks. And it was from what you would call quality of evidence, Terrible study because it wasn't blinded, it was only 10 people, it was open label, et cetera, wasn't controlled. But in terms of its effect, everybody was like, holy shit, this is pretty amazing. So fast forward many years, there is now a medication that can be prescribed that is called Spravato. It's S-ketamine. Without turning this into a really boring chemistry lecture, ketamine is what's called an enantiomeric molecule, which means it comes in a left and a right-handed version. And in nature, you'll get 50-50 distribution of those things. It looks like S-ketamine and R-ketamine, which is the right-handed version, work about the same. Sometimes only one works. The reason that Spravato is S-ketamine is because you weren't able to get a patent on what's called racemic ketamine, which had both of them. So basically, in order for a pharmaceutical company to make money out of it, they had to separate out the enantiomers and just use one of them. So that S-ketamine, or Spravato, is an intranasally administered version of ketamine. But because ketamine was already FDA approved for anesthesia, doctors can use it off-label for whatever they want. Once you're a doctor, you can use any medication for anything that you want to. I mean, you may get sued for doing it, but there's no restrictions. And so what sprung up after there was more and more evidence that this early study with 10 patients wasn't just a fluke, what sprung up were many, many what are called ketamine clinics, most often not run by mental health care providers, and that doesn't mean necessarily that they're bad, right? Actually, there's one in Los Angeles that's run by an anesthesiologist who I know, and I think he does a great job. But what ended up happening is it was sort of like the horses got out of the stable, and there was a rut because there was no ability for the DEA or the FDA to regulate something that already was out there and could thus be used for off-label purposes. There was this tremendous rush into ketamine use. And I think it should serve as a warning for those of us that are interested in making use of these other medications that are coming down the pipeline about what not to do. Because it hasn't happened yet, but I can tell you from being in the trenches on the ground, there is very likely going to be a backlash against all of the unregulated use of ketamine. I had a patient a couple months ago who's a famous actress who gets her ketamine from a doctor in South Carolina that mixes it with oxytocin and puts it in intranasal form and ships it out to her and told her you should just be using this whenever you don't feel good. And so she goes throughout her day sniffing intranasal ketamine and has developed a very bad habit. And in addition to having a bad habit, she's also developed a lot of problems with her bladder and her digestive tract. So the issue with ketamine is as follows. Ketamine is intoxicating, and it's euphorogenic. So now the people that talk about the mechanisms by which ketamine mediates its antidepressant benefits typically will talk about the dissociative effects of ketamine as being an adverse side effect, not the main effect. My personal opinion is that it actually mediates its antidepressant effects as a consequence of the dissociation. That's just my opinion, so it may not be true. But what I personally believe is that the reason that ketamine it's incredibly effective. Meaning you take somebody who's really depressed, you give them a ketamine infusion, and they will feel way less depressed immediately, and it usually extends beyond that day, sometimes up to a week. My experience has been that in practice for really depressed people, they need, the effects diminish relatively rapidly. Now, nobody actually can say with any certainty how ketamine through Nmda antagonism is mediating this effect. My opinion is that what's going on is that it is a little bit like rebooting the computer in the sense that, if you look at what's going on with people in terms of their cognitive emotional system when they're in a major depressive episode, they are obsessively looping on anxiety and shame-oriented cognitions. I'm a loser, nobody likes me, everything's terrible. and then it induces emotional states that make the world feel threatening and unfriendly. And I think that when something dangerous or unpleasant is happening, our attentional system is wired to pay attention to it, because if there's a tiger right here and you're like, I'm going to think about what I'm going to eat later, that doesn't work well. So what happens in depression is people get stuck in these downward spiral loops where they have cognitive distortions about how terrible they are, about how nobody likes them, about how they're incredibly pessimistic and catastrophic views of the world. And because they seem real to them, it attracts their attention, right? If I was able to convince you that like things were terrible, this day was going to go terribly, you'd want to know why. What is it? It would grab your attention. And so people in major depressive episodes get caught in these loops. And I do think personally that what's going on with ketamine and other dissociative anesthetics is that it helps because people dissociate. It actually enables them to move their consciousness actually away from their sense of self. And I think to some degree it inhibits that negative momentum that tends to drive depression and negative cognitions and that cycle within major depressive episodes. If that's true, I'm not sure. What I do know is that there are people that are doing ketamine-assisted psychotherapy. I don't necessarily totally understand how the effects of ketamine would augment psychotherapy, but I'm not the one to ask about that. I think there may in fact be benefits to ketamine use beyond the rapid amelioration of depressive symptoms. But here's what I personally have experienced as the problematic side of ketamine. It works too well, right? So the reality is that the goal in psychiatry, you would think, would be to find more and more and more effective antidepressants and anti-anxiety medications. That's not true. No one is ever going to discover a medication that makes people feel better more quickly than heroin and cocaine, at least in my opinion. So we'll leave it at that. So the problem isn't really about trying to find more and more effective medications. The problem is trying to find medications that are effective but don't work so well that the person ends up using them as a way to numb out their feelings and thus becoming addicted to them, right? So the reason that Prozac is usable is because nobody takes their Prozac and goes, oh man, I feel so much better, right? I would say nobody's giving blowjobs for Prozac downtown, right? And the reason is because it doesn't work that well. And if it worked better, people would be giving blowjobs for Prozac, right? So nobody's trading their commissary money for more Prozac, right? So I think the problem with ketamine is that, and listen, there are other medication classes within the pharmacopoeia that we use that are also in this gray area, like benzodiazepines, right? So there's actually even kind of a divide between psychiatrists that were trained in my generation and later, and older psychiatrists. So older psychiatrists hand out benzodiazepines like candy, and I almost never will start somebody on a benzo, and the reason is because they work too well, right? And fundamentally, in order for me to feel comfortable starting somebody on a benzodiazepine, I have to be convinced that the thing that I'm giving it to them for isn't going to last more than 2 weeks. If that thing is going to last more than 2 weeks, then starting them on a benzo now is going to be problematic, because if I don't want them to become dependent on it, I'm going to have to take it away at some point, and then it's that thing is still going to be there. The other problem with benzos is they impair new memory formation. Anyway, it's another whole topic. So the issue with ketamine that I have found is that when I've had patients that go on ketamine and not with these unscrupulous docs that are handing it out in nasal form to you, but used as it's supposed to be with like as Spravato or even as ketamine infusions like every 2 weeks or whatever, what I find is that their primary focus in their recovery is getting to their next ketamine injection or next ketamine infusion. They're not focused on doing the psychotherapeutic and behavioral work to actually heal the source of the underlying discomfort that the ketamine is anesthetizing. And that's the very problem that we have with the drugs and behaviors that people get addicted to. So we will see how this unfolds. let's move on to actually what I actually think are the more interesting drugs. So MDMA, also known as ecstasy, is an entirely different drug than ketamine. It should not be put in the same category. It belongs to a class of drugs called phenethylamines. There was this wonderful book that actually I read in Kepler's bookstore when I was 17 years old that fatefully moved me in a certain direction in my life, called Pikal. It was written by a guy named Alexander Shulgin, who was a chemist actually at Stanford, who synthesized like 100 or 200 different molecules within this one class, and then took them all himself with his wife and wrote about his experiences. And anyway, MDMA was one of those. In any case, it works by, it's what's called a serotonin releasing agent. And what it does is that it gets into the neurons that use serotonin to signal one another. And it gets into what's called the presynaptic neuron, meaning the neuron that releases the serotonin. And it basically causes that neuron to just discharge all the serotonin that's in there. This works differently, although using similar pathways as the medications like SSRIs like Prozac. The difference is that Prozac is sort of like a polite molecule in that it stays on the outside of the neuron, and it gunks up basically the vacuum that the presynaptic neuron uses to vacuum out the serotonin it just released, so that the neuron that's receiving the signal knows that the signal's over, right? So this neuron releases the serotonin into this little space in between called the synapse. This one has receptors waiting for it. The serotonin hits those receptors, activates them. When enough get activated, this one fires. If the serotonin is just allowed to stay in there, this one will just keep firing. So what this one does to indicate that the signal is over is it has vacuums called transporters that vacuum out all of the serotonin from the synapse after it's been released. Prozac and other drugs like it basically go in there and kind of gunk up that vacuum. It's a little bit like getting a dust bunny in your vacuum, right? So it's just like, why isn't it sucking as good? So that's basically what the SSRIs do. What MDMA does is it actually gets into that vacuum and vacuumed up into, it actually goes into this molecule, and then essentially more or less through many different mechanisms causes all of the serotonin that's in there to just get released all at once. And so it floods the brain with serotonin. Now, serotonin is a really interesting and ubiquitous molecule in our system. It's used on our platelets, it's used in our digestive tract, it's used in our brain, obviously, for lots of different functions. One of its functions appears to be the mediation of affiliation or attachment. And so when you flood the system with serotonin, what people tend to experience is overwhelming feelings of affiliation, attachment, and love. And that's why people take it at raves, and when people take MDMA recreationally, they're taking it for that experience. It's a feeling, it's a positive feeling of attachment with other humans. And that's why when you see people doing it, they're like rubbing Jergens on each other and, laying on a big mattress together. So I don't know, do people do that anymore? That's what they were doing when I was in college. You know what I mean? It's like you'd show up at a party and it's like, oh, okay, there's the Jergens. Everybody's rubbing hand lotion on each other. It's one of those kind of parties. And then what was it, the menthol things too? I never got that either. Anyway. This drug is being looked at right now for potential medicinal purposes. It is historically, and to this day, still actually classified as a Schedule I drug, meaning it's deemed by the DEA to have no medicinal benefit, but they are allowing actually certain people to do studies with it now. And it's being looked at for post-traumatic stress disorder, depression. I actually think there's some promise here. To me, the main area that I think would potentially be really useful for are people who have both autism spectrum disorder or really significant traumas related to attachment or assault. Because one of the things that happens is that when we have been traumatized in the context of an important relationship and attachment, we now then become cued to get all our defenses up anytime that it looks like we might be in another attachment. And for humans, our only adaptation is our attachment with other humans. We don't have claws or teeth or anything. We survive by the ability to form attachments with other human beings. And so it's a really paradoxical and painful state to exist in if you are a human that's been traumatized in the context of a relationship, which is actually where most traumas happen, and you have sort of, every time you get close to somebody, you start having all of your trauma defenses come up because you're like, oh, this is where I get hurt. And so I do think to some degree there may actually be, particularly in combination with good psychotherapy, I actually think that there may be some real benefit there. And I think from a risk perspective, the risk of MDMA is mostly what you would call toxicity risks. You can induce something called serotonin syndrome. If people are prone to bipolar disorder, you can induce a manic episode. I don't see super grave psychological risks associated with MDMA in the same way that I do potentially associated with the next drug that I want to talk about, which is psilocybin. So psilocybin, and this is the final one, and I'll make this go quick because I've only got a few minutes. Fuck, this was the more interesting one. Oh well. So psilocybin is actually a psychedelic. The other two drugs are not psychedelics, even though they commonly will get discussed in the same breath as psychedelic when people are talking about psychedelic medicine. Psilocybin is actually what's called a prodrug, meaning it itself isn't pharmacologically active, but when it gets into your body, your liver converts it into something called psilocin, and psilocin is an active drug that has psychedelic properties. Now, there are many, many, many drugs out there, compounds that have psychedelic properties. LSD, psilocybin, psilocin, DMT, they go on and on and on. Mescaline. What they all have in common is the thing that makes them psychedelic is that they are serotonin 2A receptor agonists. So remember I was talking about ketamine being an Nmda receptor antagonist. So all drugs that have psychedelic properties are serotonin 2A, which is just a subtype of serotonin receptor agonists, meaning they fit into that receptor and they turn it on. Again, why does that cause the effects that people experience when they take psychedelics? Nobody knows. So let's now move into Jason's opinion part of what's going on. So if you ask people what their experience is when they take psilocybin or they take LSD, they will use words like profound, spiritual. They'll talk about God or higher power. One of the studies that recently looked at the use of psilocybin for the treatment of depression and anxiety in terminal cancer patients reported that the majority of patients reported that the experience of taking it was one of the 5 most profound experiences that they had in their life. So clearly, there's something really significant that gets induced when people take these drugs. And I think that's where a lot of the excitement is about their potential use, because it creates something in a very, very, a single dose that people rate as, again, one of the 5 most profound things that's ever happened to them. So what's actually going on there? So this is my hypothesis about what's happening from a psychological perspective when you activate the neural pathways that use serotonin 2A receptors as a way to signal one another. So getting all the way back to the beginning of this lecture, where I talked about the importance of attachment. So I think that there is a psychological process that starts the minute we come out of the womb and continues probably for the first many years of our lives when we're children, that involves forming an attachment with our parents. And if you try to imagine what it must be like to be in a relationship with a parent when you are a baby, think about what that would actually feel like. So you are just born, you have no idea, all of a sudden you went from not having any consciousness to consciousness, you're entirely helpless, and there's this huge creature that somehow knows how to do things, and when you're hungry, it feeds you, but it's not always there when you want it, and you can't even understand, trying to understand what that thing is doing or what it even is would be like a mouse trying to understand prime numbers, right? It's just you can't even conceptualize what this thing is. My personal opinion is that what people describe as spiritual experiences are adult remnants of this process that takes place in the attachment between little kids and their parents. And I think it makes sense of some otherwise difficult to explain things, which is why, like, people cross-culturally agree that spiritual experiences have something to do with feeling subordinate to some significant power, being included, being part of something that's bigger than yourself, and being somehow deeply meaningful, but also powerless, right? Meaning there is this thing that's so much greater than yourself. And I think that that's kind of exactly the things that are part of the child or baby side of the relationship in our relationships with our parents. And I think if you imagine that for children, so imagine what it would be like if you knew for sure there was a God. Not only did you know that there was a God, but you actually knew them, and you had a daily interaction with them, and you were entirely dependent upon them for all of your needs getting met, right? Imagine now what happens if God's upset or angry with you, or God's depressed and crying, or God's high and can't pay attention to you, right? Those are starts to start give you a feeling of what it's like to actually be a child in a relationship with a parent that isn't healthy themselves. And I think that I think one way to look at, let me put it this way, what I view as the goal of recovery, meaning healing that shame-based part of yourself, is actually learning how to treat yourself or view yourself the way a healthy, loving parent views or interacts with a child, right? Which is, you're valid and lovable and good, not because of what you do or don't do, just because of who you are existing, right? So a healthy, loving parent doesn't wait to find out if their kid's good at violin before deciding if they're gonna love them or not, right? So, right, but a not healthy parent, might not be able to attune or express love until they find out if their kid's good at violin. And then that kid grows up with the basic fault being like, oh shit, if I don't perform, I'm not lovable. So I do think that psychotherapy is the main way that you help people with this, because it is fundamentally a software problem that we have, not a hardware problem. And the way that we change our software that we're running, particularly the part of the software that we run in our brain that results in our conscious experience of our sense of who we are, and are we lovable and good, or are we bad, or is our lovability and goodness conditional on certain things, the way that gets reprogrammed is through relational experiences with other human beings. And I think it is therapist-patient or therapist-client relationship that actually is the mechanism through which that reprogramming can happen. I do think there is something about activating that serotonin 2A system that puts us into a state of activity of that system that we're in when we're little kids. And I think there probably is some degree of ability to accelerate the process of sense of self change that happens in good psychotherapy. However, the problem with being a baby is that you are entirely and totally dependent on your parents. And you don't have any control over whether you're born to a healthy parent who's going to take care of you, or a parent who is on drugs and shouldn't be pregnant and is going to decide to throw you away in a dumpster. So there's a lot of potentially mortal level anxiety that can be induced when you open up that system. And I think, unfortunately, people who are real big advocates of giving everybody psychedelics are people who have done psychedelics and had great experiences on them. But there's a shit ton of people out there who've done psychedelics and had really terrible experiences, like abject terror, right? So I think that until we have a better understanding of what we're doing relationally with our patients, the idea of just giving them psychedelics and seeing what happens as though the psychedelic experience itself is somehow going to magically be healing, I think is irresponsible. I think it can be healing for certain people depending upon what they're coming into the experience with. And one of the things that we hear a lot is set and setting. So, right, it's this people's trips on psychedelics have a lot to do with what they're going in with expectation-wise. But fundamentally, if what you learned from your primary attachment, particularly if it was very early, was that that's where you got hurt, and then you give somebody a drug that activates that system, of vulnerability, I think there's risk there of really profoundly disturbing that person. And one of the most basic tenets of trauma therapy is resourcing. You don't do any content work. You don't touch the trauma until the person is sufficiently resourced. The person has to have an ability to create a place of safety and to self-soothe in order to be able to go back and start reprocessing the trauma. Otherwise, you just open it up and it's re-traumatizing again. Otherwise, it's like, oh shit, that terrible thing is happening again, as opposed to, oh wait, I'm safe now and I can learn that actually this terrible thing is over. So, I don't know. Those are, again, just my thoughts about the way in which these drugs work. I think, like it or not, the train is barreling down. There's going to be these medications. Psilocybin is going to become FDA approved relatively soon. But I think especially for those of us in recovery, it's really important to have an understanding of A, how these drugs work, and B, have an understanding of what are the relative risks and what are the relative benefits of them so that we can talk responsibly and intelligently to our patients and our clients when it comes up. So, all right, it's 12:39. Thank you.